And I want to welcome you to today's webinar, Advanced Endoscopy and Ancillary Services. A few housekeeping items before we get started. All attendees are on mute, so during the presentation, either jot down your question and select the hand at the bottom of your screen, and your line will be unmuted during the Q&A session. Or if you're listening by phone, you'll need to go to the Q&A at the bottom of your screen and type your question. If you can, you can do that either way, whether you're on phone or not. Please don't put your questions in the chat section, so that way I can kind of track all of the questions in one place. The handout was sent out yesterday afternoon, so if you need me to resend it, you can just email me at lynn@askmillerconsulting.com and I can get that back out to you. Today we've got Kathleen Miller on the phone to do the presentation, and you should be able to see her screen, and I think we're ready to go.
Hey, thank you, Lynn, and welcome everyone. And today we're going to talk about quite a few things. The overview, we're going to discuss EMRs, ESDs, fistula closures, myotomies, the intragastric balloon necrosectomies, EUS, TIF, cystogastroscomies, chromoendoscopies, endomicroscopy. We're also going to be talking about the proper documentation that is needed for unlisted procedure codes, and some things that will have to be done by some of your providers and yourselves in discussion with a payer in order to set up some pre-approved payments. We'll also be going to talk about billing for dietary counseling, and then also the proper documentation of GI diagnostic studies and any radiology services that you might provide for your patients as well. That the documentation is key, and I mean not just for the diagnostic studies, but also for our endoscopies procedures as well. And I think for those of you that have been on the Medicare sites and been updated on our information, if those of you are in support or listening through, we've been talking about validating medical necessity for a long time. All right, and this is a focus by payers, not just Medicare. So all of that has to play a role in proper documentation and assigning the proper codes and pre-authorization of services prior to our at the time of scheduling. All right, so let's go ahead and begin. The first thing we're going to talk about is endoscopic mucosal resection versus snare and saline injection. I know those of you listening pretty well know we offer support, and part of the support feature is that you're allowed unlimited questions. And this is probably a question that we answer 3, 4, 5 times a week, is what documentation do I have to bill an EMR, or what is the difference between it? Unfortunately, there's nothing that's just so cut and dried with this. I'm going to tell you what the code includes. So the EMR code for colonoscopy is 45390. For upper GI endoscopy is 43254. And there's one for esophagoscopy. There's also one for sigmoidoscopy. But it all basically includes this information. So it includes any type of injection with saline or methylene blue or Elevue or any solution that's out there now by different manufacturers and vendors. And it's mainly designed to demarcate the lesion and basically set up where the boundaries are, where the lesion ends. Snare and or banding or other special device to remove tissue, and any clip application to close a defect that was created during the resection. This technique is usually applied to larger flatter, which are sessile top polyps. It's often considered a 2-step procedure by payers. And because it's considered a 2-step procedure, often this creates a prepayment review or a pen situation where the payer won't pay you unless they want to review your records first. They want to make sure that there's a lot of detail, that the term endoscopic mucosal resection was documented within the report, and a complete description of the procedure that you did. Sometimes endoscopic ultrasound or EUS may be separately billed, even for the same lesion, if it's clinically warranted, mainly just to check to see how deep this lesion goes, in other words, to make sure, and also to make sure that they got everything. All right, so again, this is not a simple lift and snare situation. All right, and because it's considered a second step, and this is, the payers did this back in 2016 when we got these new codes. We had the upper GI endoscopy code with the EMR before we had the colonoscopy codes. And the thing is, the payers, when they set this up, when they put their policies, and let's put it this way, their standards in play, that how they're going to process a claim, one of the things that they did was they assumed that this was not going to be done on an initial procedure, because the EMR is considered an advanced technique and not all GI providers do this. So oftentimes at this point, and we're seeing this has increased dramatically over the past few years, where practices have now have physicians, advanced endoscopy physicians in their groups, and those providers will do an EMR on the initial presentation, even if the patient came in for a screening, meaning they had no symptoms at the time. So because of the fact that we have more and more providers doing the EMR, the review situation that's set up by payers, that they stated that this was considered more of a stage 2 procedure, that the step first was to do the biopsy, and then step 2 was to send that patient to someone who would do an EMR to remove it. All right, so that's the reason why this gets into a prepayment review situation. And specifically, if you're putting a PT or 33 modifier on the code for screenings turned into an EMR situation, the payer, I can guarantee you, almost 98, 99, almost 100% of the time, will pen the claim and want to see the documentation to make sure it wasn't just a little saline lift and a snare situation on a pedunculated polyp. All right, so again, they want to make sure that your documentation is clear in the medical record to truly support an EMR. All right, so if the provider documentation supports a saline lift polypectomy, then you can still bill 45385 and a 45381 combination. Although I'm telling you that we're starting to see some payers pen to these as well. So 45385 with 45381. There have been a couple of payers out there that have stated that if it's truly just a saline lift, they may not cover that as a separate. If it's something for tattooing purposes, they will consider it billing in addition to 45385. I don't have anything in writing to support it. All I'm relaying is what I've been told by several of our clients, is that they're starting to see that the 45385 and 381 are now put into a denial situation or append to say they're considered a bundled service. All right. So communication between the coder and the physician is essential for accuracy of the claim. So coders, if you're listening in here, if you see an EMR, or if your physician assigns a code EMR and you're not really seeing a good description in the endoscopy report, since there's a high percentage that this will be pulled for review before payment, I would recommend that you get back to your doctors, speak with them, discuss this further, and have them do any type of a legal correction to support the EMR. We want to make this as bulletproof as possible. And unfortunately, the difference in reimbursement is really not significant between 45390 and 45385 with 381. All right. But, it is still a higher reimbursement. And that's one of the things, and that's one of the reasons the payers look at this more closely. All right. So here's an example. Colonoscopy with EMR. Patient is a 77-year-old male who had a recent colonoscopy and was found to have an advanced polyp in the ascending colon. So this actually is more considered as a stage 2 or a second step procedure. All right, this was about 1 centimeter distal to the ileocecal valve. A large complex polyp was noted. It was 4 by 4 centimeters and encompassed approximately 40% lumen. At least 20% of this large polyp was located behind a fold. And so there was a mixture of hetastarch, epinephrine, indigo carmine, and parts of the lesion was lifted. It doesn't matter what was injected in there. If anything was used for demarcation purposes, it's still considered part of an EMR. It was then removed by hot snare technique. There was remnant tissue. This area was also injected for a lift and was removed by snare. The surrounding lumen was very edematous and hard to distinguish. 5 resolution clips were placed to close the defect. Now this is for the snare polypectomy and lift situation. The indication was screening. The scope was introduced. One 15 millimeter polyp was found. It was semi-pedunculated. The polyp was removed with saline injection. Lift technique using hot snare, resection, and retrieval were complete. So that clearly defines 45385 and 45381. All right, endoscopic submucosal dissection. And now this is more extensive than the resection. It is similar to an excision of a lesion of the colon, or the esophagus, or the stomach, etc. So they're doing an endoscopic approach to what would normally have been a laparoscopic or a open procedure of these organs in particular. So because this is truly an unlisted procedure code, what you have to do is you have to use that unlisted procedure code, and then you're going to compare it to something that's closely related, even if it's not an endoscopic procedure. So for 45399, if it's an unlisted procedure, the colon, if you're doing a dissection, it would be comparable to CPT code 44110. If it was of the esophagus, it would be comparable to 43499, which is the unlisted procedure of the esophagus, and it would be closer to 43100. And 43999, which would be an unlisted procedure of the stomach, it could be comparable to either 436610 or 43611, depending upon the type that you're actually removing. So I'll tell you a little bit further when we get into how to create a fee and how to get paid based upon that when we go into that slide. Several slides back from this. Endoscopic closure of a fistula. All right, so we also see this being done. Fistulas can be in any different area of the body. Most commonly, we see one in the stomach, especially for the stomach and the abdominal wall, which is mainly a gastrostomy site. There also could be a fistula between the stomach and the jejunum, or one between the colon, and it could be the bladder, or it could be the colon, or the rectovaginal fistula. It can be anywhere within the GI tract. So oftentimes a clip placement is done. It can also have a cap placement of the fistula opening at the center of the endoscopic cap, applying firm suction through the endoscopic channel, deploying the clipping device by turning the firing wheel. Then the fistula opening was approximated with a clip, and using forceps and an endoclosed device is then removed. So this is kind of the description that you'll see with your physicians when they're doing this procedure. So we're going to utilize for the stomach 43999, and the comparison would be for an endoscopic closure of the gastrostomy, or for open closure of the gastrostomy. 44799 for the small intestine, or 45399 for the colon, and you can use a comparison code of 44640, and 45999, which would be, say, the rectal fistula of some sort. You can use a comparison code of 5C7300. All right, so again, making sure when you're using an enlisted procedure code, one of the biggest things is how you develop your fee schedules. You have to have that comparison. The POEM procedure, which is a peroral endoscopic myotomy, this is actually used to treat alkalasia. Oftentimes, alkalasia is treated by either a thoracoscopy or a thoracic approach or even an abdominal approach. So since this is an endoscopic approach, we would want to use the RVU similar to laparoscopic or thoracoscopic approach. And there are no specific codes for this. You can use the 43999 for the unlisted procedure of the stomach, and then you use these codes for 43279 or 32665, depending on which approach was done. The intragastric balloon procedure. All right, now I don't know if any of you are doing this, but Some practices are, some practices are not. But basically what this is a balloon that's inserted in the stomach, and there are different manufacturers of this device. But the problem with this is these patients are self-pay. None of the payers up front are allowing this as considered a standard of care. They consider this experimental at the time. And so most practices that do these procedures, they provide the service as a bundled service. So it's like one fee takes care of the procedure, all pre and post-op visits, as well as the device removal at 6 months. All right, so that is the way that you have to handle this. And until the payers everybody considers, a CMS as well, considers this more than just an experimental procedure, it is going to be a self-pay situation. These are just some of the devices that are out there, or Barrow, Reshape. There's others too, but this is basically what it looks like. Endoscopic pancreatic necrosectomy. All right, so this is a very complex procedure. All right, so the only code that we have for this is an open approach, and that code is 48105. But the work value of this is similar. All right, you have to gain access to the pancreas, and the pancreas is posterior or lies behind the stomach. So in order to get to the pancreas, the endoscope is put into the stomach, and then utilizing endoscopic ultrasound guidance, the stomach, the needle instrument is punctured through the stomach into the pancreas. Sometimes it could be into the duodenum, depending upon where the cyst is, and usually this is for a pseudocyst situation. A plastic stent is then inserted from the stomach across the opening to inside the cavity, and then what happens is instruments go in and remove the necrotic or the dead pancreatic tissue, and it drops into the stomach or the duodenum. It can be suctioned out, or it can just be put in there for excretion. Most of the time it does get suctioned. All right, but the thing is this already is gaining access is 43240. So what I described was the cyst gastrostomy. All right, that does not include the necrosectomy. All the cyst gastrostomy does, and that code is 43240, is just perform a bridge into the pancreas. So it's a connection for drainage purposes. But it also allows then an opening into that area for the physician to go in and endoscopically remove the tissue. This is not an easy procedure. It doesn't take 5 to 10 minutes. It can often take 30 minutes, an hour, or more. And it is risky to the patient. So the RVUs for 48105 are 80. That's a lot. All right. And most of the practices who have negotiated with payers, even including Medicare, have been successful at gaining reimbursement, something similar to 80 RVUs. All right, so again, I'll go into more information as to how you go through this, but again, you want to make sure to compare it to something similar, and there is nothing similar except for that open approach. EUS, endoscopic ultrasound. So that is designed to look through the wall of the GI tract to any type of lesions into both the GI structures or the adjacent. All right, there's two basic categories within EGD, and one is the limited and one is considered the complete. Now, before we get to the differences between that, most of the time your doctor will put the standard gastroscope in prior to the insertion of the endoscope. So to make sure that there's no other issues than what they're going to look for with the EUS. So if the end point of the scope is the small intestine, all right, then the EGD category will be chosen. If the end point is the stomach, then you're going to look at the esophagoscopy categories. And if the end point is the cecum or ileum, colonoscopy. If the end point is no further than the descending colon, then sigmoidoscopy category will be chosen. All right, so that's one of the things is we want to make sure to choose the right category. Now, since January 1st of 2014, the code 43237 was revised to include less than 3 areas of the GI tract with adjacent areas, hence the term limited. It used to state limited to the esophagus only, but now it's just considered limited. All right, so it says in the description, esophagus, stomach, or duodenum with any adjacent areas. All right. In order to bill 43259, which is the complete EUS, that your doctor has to indicate that he or she examined all 3 areas of the upper GI tract with the use of the ultrasound. Not the fact that the scope, the standard gastroscope, was put into all the way down into the small intestine. Not the fact that the EUS scope was also inserted all the way into the small intestine, but what was viewed with EUS were all of these areas plus any adjacent areas. So the example, echo imaging was performed through the esophagus, stomach, and duodenum is a statement you need to make sure that's in the medical record, in the documentation for the EUS, on your endoscopy report. When performing an EUS and a biopsy is done separate from that site, we can use modifier 59 on the biopsy. But make sure that the diagnosis is specific to the EUS and the biopsy diagnosis is specific to indicate the separate lesions. Even when we use the 59 or the XS modifier, either one can be used on the biopsy, you need to be prepared to submit documentation upon denial or pen of the claim, because the payer wants to make sure that you just didn't bill for the biopsy plus the EUS. All right. Now, if you actually did do an EUS with biopsy, say on a pancreatic area, and plus then you also did a biopsy with just a standard biopsy forceps on the esophageal area, both biopsy codes are billable, the 43242 for the pancreatic biopsy and the 43239 for the esophageal biopsy. But the esophageal biopsy is considered bundled into the pancreatic since it was an ultrasound-guided biopsy. And so the 59 or the excess modifier has to go on the 43239. But again, make sure to link your diagnoses to the appropriate procedures and be prepared that these are considered bundled on the explanation of benefits. So here's an example for 43259. So this is the complete EUS. Indication staging of esophageal endocarcinoma and an abnormal liver ultrasound. So there are actually 2 things going on with this patient. So it says the scope was introduced to the mouth and advanced to the second portion of the duodenum. The upper EUS was accomplished without difficulty. We at least know that we have an EGD out of this, but now we have to figure out what was actually looked with the endo with the EUS scope. It says in the sonographic findings, a hypoechoic mass was found in the lower third of the esophagus. There was no evidence suggesting invasion in the adventitia. No lymphadenopathy was seen in the stomach and the duodenum. And there was no sign of significant endosonographic abnormality in the common bile ducts. So everything was visualized with the scope. For 43237, which is the endoscopic ultrasound, all right, this is post-treatment staging of known squamous cell cancer. It was introduced in the mouth in approximately to 33 centimeters. There was significant stenosis beyond, all right. Several of the lymph nodes were round, and so technically this was just limited to the esophagus as well. This is actually the scope for EUS. It's different than our standard gastroscope, where it usually has the opening at the bottom. This is the actually ultrasound. This is your methods, your intermittent, and this is your the video, all right? And then you also have your irrigation equipment and your suction apparatus in here. So it's definitely a different scope, and that's why often the standard gastroscope is put in first before this. However, and one question probably, I think some of you are all right saying, well, then we can bill an EGD separate. Nope. Okay, you can't bill 43235. It's still considered part of this procedure, but you can bill a different technique used separate from this technique if one was done. EUS with fiducial marker placement or with injection of therapeutic substance. All right, so this code is 43253, and this is placement of markers usually for the use for radiation. It can be celiac plexus blocks or destruction. Some of our providers are using like alcohol ablation to pancreatic lesions or anything like that as well. All right, it includes radiologic guidance. It is considered the most extensive procedure of the EUS codes, and can only be billed if both the EUS guided biopsy and injection and or the placement of markers is done. All right. Transoral incisionless fundoplication, otherwise known as TIF. And I know some of you guys are doing this procedure, but this is truly has its own code. And the code is 43210. So it's mainly corrects the root cause of GERD, which is the defect of the GE junction or the GE valve. And it's inserted transorally with guidance with the endoscope, and the S-affix device is used to reconstruct the valve, in other words. All right, so the code is 43210. It includes any type of diagnostic EGD or esophagoscopy, and it's an option for selected patients in which laparoscopic or open fundoplication is being considered. Now, the question with this one can be, well, I also work with a surgeon on this one, and they repair the diaphragm, so there's a hiatal hernia. And so we've billed the 43210, and we've gotten denied on this. And I can tell you why. Because if the surgeon is billing the hiatal hernia repair, it includes any type of fundoplication when done. So if you got denied on it, that means the surgeon got their bill in first. Right? They got paid for it. Right? It's actually considered a 62 situation. So if you're working with a surgeon and you're doing the fundoplication, the surgeon is fixing the hernia, then you should be billing the surgical code with a 62 modifier. So that means the surgeon and you have to work together. That means that you each have to have your own op notes. It means that you also have to have something on there that says surgeon and surgeon or co-surgeon and co-surgeon. And since this is an elective procedure, that means your pre-authorization department also has had to do what? Pre-authorize this as a co-surgical procedure. Not all payers will automatically pay the hiatal hernia repair codes with fundoplication as a co-surgery. All right. It does help that two separate specialties are involved in this, but oftentimes information is required as to why two surgeons were necessary for this. So again, guys, I just want to make sure that you're aware of this, that if you work with a surgeon, there is a potential conflict. If you do this without surgical, right, you're doing these by yourself, you have no issues. All right, it still has to meet the requirements for pre-authorization, and every payer has a little bit of different guidelines on what needs to be documented in the medical record to support medical necessity for this procedure. All right, so this is pretty well the devices that can be used for the TIF. The pancreatic cyst gastrostomy, I pretty well kind of talked about this before when we were talking about the necrosectomy. So this is exactly what the providers are doing. Their stomach is right here. Here's the pancreas. Here's the cyst. And so somewhere in this area, they're going to puncture through the stomach wall into the cyst, create a conduit, place a stent, so it can access the pancreatic pseudocyst in particular. And remember, when you bill this code, the stent insertion and the endoscopic ultrasound are included, and it is not separately billable. Chromoendoscopy, which is a stain usually applied to the mucosal lining of the GI tract. Unfortunately, this is not considered separately billable. Since it's a chemical application, it's considered a component of standard endoscopy. Now, I do know that some of the practices have said, well, that's just not fair. We should be able to get an additional money for that. So they actually build it as an unlisted procedure code. Most are successful in getting paid, but it's still most commonly they're getting the standard amount of just the diagnostic part of that procedure, whether it be EGD, esophagoscopy, or colonoscopy in particular. And this is kind of the white light and the iodine in particular. All right, optical endomicroscopy. Okay, so the physician views any abnormality of the mucosal lining using an endomicroscope that is attached to the esophagoscope, for instance, for esophagoscopy. That's the most common one. This can also be done with EGD as well. It can also be done with ERCPs. So I'll talk a little bit about that in just a minute. So what happens is the endomicroscope uses laser light to magnify these cells in order to identify histopathology in real time. So it's a pathologist in a scope, in other words. So the CPT codes are reported. So 43206 is for esophagoscopy. 43252 is for EGD, and 0397T, it's a T code, so it's a category 3 CPT code, is used for ERCP with optical endomicroscopy, and it's an add-on code to any ERCP code. And we all know with the T codes, they're not necessarily payable. So Medicare does not usually accept the T codes. They would have you bill this as an unlisted procedure of the biliary tract. All right, so this basically, you've got the endoscopy, and then you actually have the microscope. So it's like I said, the microscope or the pathologist within there. So how do you bill for unlisted procedure codes? Well, first of all, payers will automatically deny any unlisted procedure code, and they'll request documentation. Most of these procedures are not elective, so you should have time to get elective pre-authorization and eligibility. Now, again, sometimes your docs do run into this during a procedure that they didn't intend to find anything in particular, but for the most part, most of these are elective. So elective pre-authorization and eligibility are essential, and this is often where your doctor has to be involved with negotiations on this. So first of all, when you bill any unlisted procedure code, you have to include a procedure description in box 19 of the claim form. If you do not, Medicare will deny your claim without this information, and the denial will read that the claim is unprocessable. It will require you to do an error and logging adjustment on the claim and submit a new claim. You always wait for the denial to submit appropriate cover letters and documentation. If you don't, you're going to get errors that say duplicate claims. And if you get a duplicate claim area, that's not a good thing. Medicare or CMS has always said that before you submit another claim, allow 30 days for processing before you attempt to submit anything else, even a corrected claim. So be sure that documentation states the complexity and time involved in advanced procedure cases. And providers should create cover letters, and this is the most important part of this. You need to work together with your providers that do these procedures. For all unlisted procedures performed, it should contain information as to the benefits of endoscopic versus open and laparoscopic procedures. Any patients, and what you want to talk about is what is the benefit of this. So it's patient-shortened outpatient stays. There's a return to work that's sooner. Of course, less money from the payer and the patient. That's the kind of information you want to put into this. And also you want to gather information from the hospital as to the cost of a hospital stay for any invasive procedure as like a comparison cost analysis. There is something called HCUP, H-C-U-P. You can just do a browser for that, but that's a hospital utilization profiles in particular for the average cost of hospital stays. Successful negotiation with payers has been accomplished by practices, and again, by having providers and billing staff meet directly with the payer representatives and sometimes the medical directors at the payers to establish set fees for unlisted procedures. So if you establish a set fee, you put the description in your comment field, and then often will automatically get you that set fee instead of having to submit documentation every time an unlisted procedure code is done. All right. So again, you want to create a fee schedule that is appropriate. And I kind of told you how to do this, and this is where you need to work with your physician. All right. You actually have to sit and look at a CPT book together on some things. If they're doing something, what is this similar to? And most of the time, if you're using an unlisted code, it's not really similar to any of the other endoscopic codes you have. All right, so most of what you're going to find is the technique that's being used, not the entryway. All right, don't necessarily look at the entryway when you're looking at a fee that is comparable. You're looking at the technique that was used. All right, so let's go on to nutrition and weight loss services. And I know some of you have dietitians in your practices, and if some of you are thinking about hiring a dietitian, and you're strictly GI, you're going to have a lot of self-pay on this one. So your nutrition and weight loss services, for instance, can be done by mid-level providers. And if it's a mid-level provider or advanced practitioner, APPs, you're going to use your standard E&M codes based on time through counseling and coordination of care. That's what you're going to use. The nutrition codes themselves are billed by registered dietitians, and they're billed under their NPI numbers. So the use of the group counseling codes and individual counseling can be billed based on time and documentation. But here's some issues with this. Medicare does not recognize these codes for conditions other than diabetes and renal. All right, so outside of that for Medicare, this would be considered a self-pay situation from the patient. So if you're talking about celiac, if you're talking about any type of gluten, if you're talking about either diets, IBD, or anything like that outside of the renal and the diabetes, Medicare will not cover that. All right. For our commercial payers, some will, some may not. But predetermination, pre-authorization should be done on these patients. Non-covered conditions, that's a cash-pay situation. So a lot of groups that have a dietitian are in that self-pay situation. And you have to realize it's not bad to do this that way simply because if it's not going to cover for you, it's not going to cover the hospital either. So if you want the patient to have this done and you offer the service, your out-of-pocket costs are going to be less than the hospital. So it's still considered a good option for your practice. Nutrition and weight loss services, there is a code for 97802 medical nutrition therapy. These are by your dietitians, 97803 and 97804 for the groups. And it's all a time-based situation. The next one is GO447 and GO473. And this is face-to-face behavioral counseling for obesity. And it sounds like, wow, Medicare's going to pay for that. All right, and it's a G code, which usually means a Medicare code. And there's information in there. I've got a link for you. But if you look to see who gets paid on these, it's only payable to providers when employed by these specialties. General practice, family practice, internal med, OB-GYN, pediatric, geriatric, nurse practitioner, CNS, physician assistant. And you're going, well, we have NPs and PAs in our practice, so that means it should be covered. It's only payable to providers when employed by these specialties. Gastroenterology is not on this list. All right, so that's the problem with this one. Even though it sounds like a really good code and we do this service, unfortunately, it's not something that we can bill for. All right, so let's talk about diagnostic studies. This is an area I think a lot of times we don't see necessarily all the documentation components that are required, and we sometimes don't see medical necessity well documented for this as well. So what needs to be on the reports is similar to what you're going to have on almost everything you have in your medical record. The name and the location of the facility, and obviously the patient's demographic information, the referring provider and the ordering provider, the date the test started or the device was placed or swallowed, the date of download if separate from the date of insertion. That one is not necessarily on everything we see. Probably not as important as the date of interpretation and the signature of the interpreting physician. We also have to have the indication, we have to have the description, and we have to have the impression and recommendations. So otherwise the assessment and plan based upon the interpretation. All right, so because of this, there are really two required elements for diagnostic studies. We need to have the date of swallow, the date of placement, the date the service was started, and we have to have the signature and the date of the interpreting provider. Make also sure that there is documentation of data such as waveforms and swallowing studies or any images that have additional documents besides the final report, and make sure that all the demographic information is documented. One thing I don't have on this is I just want to make sure that you understand the dates in particular. So CMS CMS published this year that they finally gave us what date of service we need to have. All right, the date of service for anything submitted with modifier 26, which means you don't own the equipment, you just do the interpretation, is the date of interpretation. If all you did was the placement or own the equipment, but you don't read it in particular, and you're going to just submit with a TC modifier, that's on the date of placement. If this is a global situation where you both use, you read it as well as you own the equipment, then you're going to bill it as a global procedure, but you're going to bill that on either the date of placement or the date of interpretation. So that's CMS. Now, as far as the commercial payers go, this is where you're going to have to set up a spreadsheet by payer to see what dates they want. Most of them actually want the day of placement, all right, not necessarily the date of interpretation. All right, so again, that's something that you do need to set up by payer to know who wants what. All right, so some of the specific studies that we work with are manometry, pH and Bravos, impedance capsules, the FibroScan, any type of motility studies, manometries, EMGs. And I know a lot of you guys do not do EMGs, and not everybody does the anal rectal as well, but these are some of the specific studies that we deal with. We also order, and some of us also have CTs in our practices, and ultrasounds and radiologic studies. You have to follow state, local, and federal credentialing requirements for any of these diagnostic studies. For CT scans, for MRIs, or anything like that, predetermination is a must. Some physicians think, oh, we'll just send the patient over to get this done today. Don't worry about getting this pre-authorized. Yes, you do have to worry about it. Some of them will not even give you an authorization on that same day. All right, so again, medical necessity is key for all of this. And then make sure to access and distribute your Medicare payers LCDs to all of our providers, to all of our staff in pre-authorization, our clinical staff as well, our coding and billing staff. Everybody should know what the guidelines, limitations. And it's not just anymore just a Medicare issue. Payers, especially on upper GI endoscopies, have specific limitations and guidelines for just standard baseline EGDs as well. We've always had ones for colons. We've always had some for EGDs from Medicare, but not necessarily from the commercial side. So more and more commercial payers have also been publishing their LCDs or their policies in particular. So if you're looking at anal rectal manometry, EMG, biofeedback training, these codes are listed right here. Biofeedback is difficult to get approved. It follows specific guidelines. A lot of the payers consider this a experimental issue. So make sure that your patients are aware that this may not be covered. All right, so usually what's covered for biofeedback, these are the diagnosis codes. Cauda equina, constipation, anal spasms, and all fecal symptoms codes are usually in there. All right, so biofeedback is effective for treatment of urinary and fecal incontinence. And these are just the guidelines for this. It requires direct supervision. All right, and again, always check your payer policies on this one. Now, pelvic floor rehab and implantable neurostimulators, I know several of you are doing those as well. This involves physical therapy. All right, physical therapy has its own guidelines in particular, and you're going to have pre-authorization and verification of eligibility for all of this. So these are just some informations on your evaluation codes for this. And then some of the CPT codes that are used as part of physical therapy are on this slide. And treatment time is usually based upon 15-minute intervals. And if only one service is provided in a day, providers should not bill for services performed for less than 8 minutes. So it's truly a time-driven way. All right. So fecal incontinence is not necessarily an automatic approved diagnosis codes for treatments. So some of the other common diagnosis codes that can be covered for are spasms or other disorders of the anus and rectum, and then any sacrococcygeal disorders as well. Neurostimulators, I can tell you right now, the only approved diagnosis code for this is fecal incontinence. And your docs tend not to do the permanent implantations. You often will do the temporary implantations. And some of the codes for these are, for the test phase, is 64561. And then any type of permanent issues, in particular 645590, as well as 64581. The analysis of any generator system is also an add-on code that would be done. And some of the documentation for this service is that there has to be chronic fecal incontinence of greater than 2 incontinent episodes on an average week, longer than 6 months duration, documented a failure or intolerance to conventional therapy, a successful percutaneous test stimulation with at least a 50% improvement of symptoms, and a condition not related to the anal rectal malformation or IBD, and it can't be related to a neurologic condition. All right. So overall, you want to make sure that eligibility is verified for any testing, procedures, or surgery. Documentation is present in the patient's record. Make sure that the patients are aware of any financial responsibilities, since some of these are considered investigational from payers. So for physical therapy services, Medicare has also imposed a monetary cap on services per year, and the CMS website has way more information on this as well. All right, so the webinar today is eligible, I think you all know, for one CEU, and contact MJ at the end of this, and she'll get taking care of this for you. I know we've got some questions over there, and I'll get to them in just a minute. We have some webinars coming up for medical necessity, auditing E&M with new guidelines, and we have some new E&M codes after the first of the year as well, and coding for infusions and injections on December 17th. And any other topics you would like us to speak on, please let us know.